Pheochromocytoma is a catecholamine-secreting tumor of the adrenal medulla that may cause life-threatening hypertension. Word Pheo stand for dusky, chromo stand for color while cytoma stand for tumor. Therefore, it is a tumor that has dusky color. The tumor develops in specialized cells called chromaffin cells which situated in the center of an adrenal gland. These cells produce three catecholamine which are epinephrine, norepinephrine and dopamine. This tumor is also known for its TINs rule which are 10% malignant, 10% bilateral, 10% found in children and 10% found outside of adrenal gland which called as paraganglioma.
Causes. The exact cause is unknown. However, approximately 1/3 of the cases is hereditary. This is due to the mutation to certain genes that are inherited as autosomal dominant traits. Genetic diseases are determined by two genes, one from father and one from mother. Autosomal dominant genetic disorders occur when only a single copy of an abnormal gene is required for the appearance of the disease. The abnormal gene can be inherited from either parent, or can be the result of a new mutation. The risk of passing the abnormal gene from affected parent to offspring is 50% for each pregnancy. Next, pheochromocytoma is associated with three syndromes as the secondary causes. There are NF1 which stand for neurofibromatosis type 1, VHL which stand for von Hippel-Lindau syndrome, MEN2A AMP, 2B which stand for multiple endocrine neoplasia type 2A AMP, 2B. Pathophysiology. Pheochromocytoma is due to excessive catecholamine secretion by the tumor. The secretion may occur either intermittently or continuously. Excessive secretion of catecholamine can cause stimulation of alpha-adrenergic receptors which results in elevated blood pressure, increased cardiac contractility, glycogenolysis, gluconeogenesis, and intestinal relaxation. Not only that, stimulation of beta-adrenergic receptors also happen which lead to increase in heart rate and contractility. Unlike the healthy adrenal medulla, pheochromocytomas are not innervated, and catecholamine release is not precipitated by neural stimulation. The trigger for catecholamine release is unclear, but multiple mechanisms have been postulated, including direct pressure, medications, and changes in tumor blood flow. Most pheochromocytomas secrete norepinephrine predominantly, whereas secretions from the normal adrenal medulla are roughly 85% epinephrine. In hereditary forms of pheochromocytoma, the secretory profiles vary according to the underlying syndrome. However, pheochromocytomas associated with VHL typically produce norepinephrine only, while those associated with MEN2 and NF1 typically produce both epinephrine and norepinephrine.
Sign and symptoms: high blood pressure, tremors, heavy sweating, diaphoresis, shortness of breath, dyspnea, headache, paleness in the face, pallor, rapid heartbeat, tachycardia, diagnosis. For diagnosis, we can perform laboratory test and imaging test. 1. For laboratory tests, measure the levels of adrenaline, noradrenaline or byproducts of those hormones in the body. Collect a urine sample for every urination during a 24-hour period. And do a blood test. 2. For imaging tests. One or more imaging tests can be done to locate a possible tumor. These tests may include CT scan, MRI, imidobenzylguanidine, MIBG, imaging, and positron emission tomography, PET. 3. Genetic testing. If a pheochromocytoma is related to an inherited disorder, it is important because some inherited disorders can cause multiple conditions, and some disorders are more likely to be recurrent or cancerous, malignant. Test results may indicate that other family members should be screened for pheochromocytoma or related conditions.
Treatment. The primary treatment for pheochromocytoma is surgery. Surgery is done in order to remove the tumor. Prior to surgery, doctor will prescribe specific blood pressure medications that block the actions of the high adrenaline hormones to lower the risk of developing dangerously high blood pressure during surgery. The preoperative medications are alpha blockers and beta blockers, which will be consumed by the patient for 7 to 10 days. However, beta blocker is added several days after starting the alpha blocker. For alpha blockers, it helps to keep smaller arteries and veins open and relaxed, improving blood flow and decreasing blood pressure. The examples are phenoxybenzamine, dibenzoline, doxazosin, Cardura, and prazosin, Minipres. The side effects might include irregular heartbeat, dizziness, fatigue, vision problems, sexual dysfunction in men and swelling in your limbs. For beta blockers, it can cause heart to beat more slowly and with less force as well as help to keep the blood vessels open and relaxed. The examples are atenolol, Denormin, metoprolol, Loprezor, Toprol-XL, and propranolol, Inderal, Inapran XL. The possible side effects are fatigue, upset stomach, headache, dizziness, constipation, diarrhea, irregular heartbeat, difficulty breathing, and swelling in the limbs. Furthermore, as alpha and beta blockers widen, dilate, the blood vessels, it can cause the amount of fluid within the blood vessels to be low and causes dangerous drops in blood pressure withstanding. Therefore, high salt diet will be recommended to the patient. This is because high salt diet will draw more fluid inside the blood vessels, preventing the development of low blood pressure during and after surgery.
For surgery, doctor will make a few small openings and insert one-like devices equipped with video cameras and small tools. In most cases, the entire adrenal gland with a pheochromocytoma is removed with laparoscopic, or minimally invasive, surgery. The remaining healthy adrenal gland carries out the functions normally performed by 2, and blood pressure usually returns to normal. In some unusual situations, such as when the other adrenal gland has been removed, surgery might remove only the tumor, sparing some healthy tissue. If a tumor is cancerous, malignant, the effectiveness of surgery might rely on removing the tumor and all cancerous tissue. However, even if all of the cancerous tissue isn't removed, surgery might limit hormone production and provide some control of blood pressure. In addition, cancer treatments can also be performed as well. First, radionuclide treatment. Radiation therapy combines MEB, a compound that attaches to adrenal tumors, with a type of radioactive iodine. The treatment goal is to deliver radiation therapy to a specific site and kill cancerous cells. Second, chemotherapy. This therapy uses powerful drugs that can kill fast-growing cancer cells. Third, targeted cancer therapies. This therapy uses medications that can inhibit the function of naturally occurring molecules that promote the growth and spread of cancerous cells.